talking about cervical cancer, the topic of this panel is the role of the public-private sector partnership in increasing access to HPV vaccine for universal health care. And talking about cervix cancer, the bad news is, as it was said already in the previous panel, that we have still too many young women mainly dying of a preventable disease, and that there are too many new cases presenting every year in a late stage. The good news, however, is that there is a long time between getting one of the oncogenic viruses that lead to cervical cancer and getting the disease. So we have time for prevention, we have time for screening and for treatment. And it was brought up by the student in the previous session that prevention and screening and early treatment are very, very important issues. I worked here in Kenya many years in the 90s when we were trying to set up cervical cancer screening, at that time with pap smear. But having a good screening program without treatment is actually unethical. If you refer women who are identified with a precancerous lesion and you cannot treat them, you are not helping them. So the best news is that now we also have HPV vaccines that are available in many countries of the world. The programs are being rolling out and are fully available for young girls. However, in many parts of the world, we still have a long way to go. And I think that is one of the challenges of this conference. How do we join forces to make sure that also in Kenya and in African countries that HPV vaccine is not only a pilot phase somewhere, but is becoming a reality. Without further ado, I'm going to invite the first speaker of this panel, who is Dr. Keegan from the Ministry of Health. Dr. Keegan is the head of the Reproductive and Maternal Health Services within DFH.
As a ministry, we have a cancer prevention program, the cervical cancer prevention program, which is hosted in the Division of Family Health. Cervical cancer in Kenya is still a big cause of mortality, with the annual number of cervical cancers coming at about 4,800. Of this, we expect an annual death of about 2,500. So as part of the program, we developed several guidelines and policies to try and guide us towards trying to prevent cervical cancer. We have the National Cervical Control Strategy. We have a National Reproductive Health Policy and a strategy that follows it. We also have the guidelines for prevention and management. And then we have a cervical cancer prevention plan. As with any program, there are 3 areas that you must focus on. 4 areas that you must focus on: primary prevention, screening and early detection, treatment, and palliative care. So as a country, we did go into partnership and held the first demonstration project on HPV, which was held which we actually had in Kitui County, one of the counties in the eastern side of Kenya. Initially, the project was for 2 years, starting from 2013 to 2014, but extended to 2015. Here it was a partnership of all the partners we have in cervical cancer prevention, and it was to demonstrate the country's ability to be able to see how that we roll it out, how we can be able to really expand the program. So we did have the 2 years done. The first year was 3 rounds, 2013. The second year was 2 rounds as per the WHO recommendations that came in for the 2 doses of the cervical cancer prevention. From the 2 years that we did, we learned quite a bit of things. The initial objective was to have a 50% acceptance, 50% target, at least a 50%, to check the acceptance and, of course, the affordability. In the first year, we did manage to vaccinate a number of 20,934. The second year, 21,937. This came to basically a coverage of the first year of 82.7% and the second year of 84.7%. That's how we did as a country. A lot of challenges came in through the implementation of the project, target setting, the partners involved in it, the partnership within ourselves. But we did have managed to get a complete, actually, managed to do the 2 rounds in completeness. So now the way is the way forward. We did the post-induction evaluation. Now we want to see how do we go as a country. Do we go back to a full national? This requires full partnership to be able to see how we can be able to roll out HPV vaccination.
The second speaker I'm going to invite is Dr. Kwahir from the Aga Khan University Hospital here in Nairobi.
I'm privileged to be here today to discuss the role of the private sector in the public-private sector partnership in access to HPV vaccine. I'd like to expand the definition of the word access to include not just physically distribution of the vaccine, which is commonly the term used in access, but in addition to distribution, to also look at the geographical and financial access. The Ministry of Health and the government in general has created several forums of which public and private partnerships are born and are created and grown. With the Ministry of Health, we've had various meetings in various capacities, including with the Kenya Private Sector Alliance, Kenya Private Hospital Alliance. But I'd like to move to argue that access to HPV must of necessity move beyond just simple Ministry of Health private hospital alliances. For us to enable or to have access to adolescent girls and to improve adolescent and childhood access or school access, health access programs, we need to make sure that the girls actually stay in school. This opens up this initiative to much wider sectors within the government. This includes prevention of early childhood marriages. It includes discussion on early sexual activity among adolescents or premarital sex. And all this then allows children to stay in school. With this, at each stage, there's a role of the private sector. There are many NGOs, there are many other non-governmental organizations, faith-based organizations that do play a significant role. It's only once the children remain in school that then the school and adolescent program can be enhanced. One of the biggest areas then, therefore, that we are able to vaccinate children before they become sexually active is during school at school going children. There's very little involvement of hospitals in accessing this particular group of patients or of children because it's not cost effective. So we must make sure that sustainability of programs is important for the hospitals and the private sector. By this I mean that there must be a difference between CSR, corporate social responsibility, and private-public partnership. Public-private partnership has to be true to mission. What do I mean by this? It has to be economically viable. It has to be within the core business of that particular institution for it to make financial sense. Whatever econometric models that we use for public-private partnership and delivery of HPV vaccines has to make sense. Now, financial sense is not purely monetary sense because there are other ways that are non-monetary benefits to institutions that the government has and continues to play a role in. For example, improved awareness or brand recognition could be leveraged on as part of value addition due to vaccinating or running adolescent programs. At the moment, the vaccination programs are heavily government subsidized, even in the private sectors. there needs to be further enhancement of this activity within the government such that the public-private partnership is worthwhile in the private sector. There are many initiatives that have come up, including some speakers that will allude to, including the global access to vaccine initiatives that are looking at enhancing access to vaccines. As we look into this area, we find that the private sector precedes introduction of vaccines, especially expensive vaccines, to the public. The private sector can act as a pilot for the government because it's small before it's scaled out. However many access or geographical access points that the private sector has, it's only a drop in the ocean compared to the population of the country. But it plays an important role in introducing these services to the community. As the clinicians get exposed to these services, they learn. There is a learning curve to it. We understand what the challenges are, and then this can be scaled up to the entire country. So there's a significant learning opportunity there. The previous panel also discussed the lack of curriculum development in terms of access of vaccines. Some of the private institutions have university programs attached to them as well. These universities programs can incorporate some of these curricula to incorporate vaccine initiatives. When you look at access, you also have to consider production of vaccines. Again, the public-private partnership is important in improving access in terms of production. Many vaccines developed in the first world are very expensive to those to people in the third world countries. We know that vaccines that have been made in third world countries, including Brazil and China, have significantly been cheaper and available to the third world countries. This needs to be enhanced through either financial incentive or non-financial incentive to private sectors. There is geographical access, as I've mentioned. Many of the private institutions currently have increased network of clinics and hospitals across the country. Now, in spite of this being fairly small, they do increase significantly the access of vaccines. And as this spreads out, it can, as I've already mentioned, be part of the rollout plan for the whole country. Now, as we look at financial access, it needs to be cost effective in terms of efficiency. So the public sector brings in a corporate approach to something that has very low margins by increasing efficiency of delivery of vaccines to the public. So in conclusion, I'd like to state that increasing both geographical and financial access of HPV vaccines is a multi-sectoral approach that includes both the private and the public sector within the ministries or within the sector of health and the sectors outside health, including social-cultural dimensions as well. Thank you.
It's my pleasure now to introduce Dr. Gatari Ndirangu. He is one of my former students. We have been working together for many, many years. And he is working with JPIGO. Most of you might know JPIGO. We will explain a little bit more, but JPIGO is an international NGO, very active in many countries in Africa. So, Gitar, what is your contribution to the cervical cancer?
Pointing out, and I want to begin with the fact that this is a golden moment for Africa. And I think we need to seize the moment. We have HPV or human papilloma virus vaccines that are available and can be able to significantly reduce the burden of cervical cancer in this continent. We must be able then to have the opportunity and to take this opportunity and have the courage to act, to be able to make a difference, so that we have to move from demonstration projects and we have to be able to actually avail the vaccines to all eligible girls in our continent, so that we can be able to reduce this burden of disease. We talked about numbers. We know the numbers. Every year, more than 500,000 women are diagnosed with cervical cancer. Most of these, 8 to 9 out of 10 of these women live in Africa. 9 out of 10 deaths that occur from cervical cancer happen in Africa. I think we should be able, and unfortunately they also occur when women are relatively young, when women are still productive in terms of their socioeconomic responsibilities. We should be able then to make a difference. We have a responsibility as the national governments, for Kenya specifically, also for the county governments to work together and ensure that the vaccines actually are available to the girls who are eligible for them. I also want to focus more a little on the private-public partnership and point out that if we do have long-term arrangements between the public and the private sector to be able to provide access to services, including human papillomavirus vaccination, we can actually be able to speedily and more efficiently and in a cost-effective manner provide these vaccines to girls, be able to have add value for money, so that we can be able to synergize between the public and the private sector with all the expertise, the knowledge and the skills that is available across the two sectors to be able to actually make a difference as we talk about effective utilization of assets that are within our continent to be able to provide these services to our girls. I know for many years we've been looking out to our development partners, and we do appreciate the role that they play with us, that they provide, the care that they provide for us. But I also want to argue that within the continent, we do have adequate, sufficient resources that if utilized them efficiently, we can actually be able to make a difference. I want to also acknowledge the fact that Gavi has been able to reduce the price of the vaccine significantly from more than $100 in a few years ago to about $4.50 in the last few years for Gavi eligible countries. We know that private-public partnerships do work. We've seen that in this country. For example, the initiative by the First Lady of the Republic of Kenya in her Beyond Zero campaign, we've seen important and useful interaction with the private sector, availing the mobile clinics. And I want to believe that if we go a step further, avail screening services for cervical cancer using the mobile clinics, be able to work with at all levels across the health and non-health sector to actually be able to avail the vaccines. I also want to argue that, basically it is a responsibility for all of us. It's not a preserve of the health sector. We have to step out of that. We have to interact with the pharmaceutical sector. We have to interact with philanthropists in our continent. And we have resources that if we were to channel them towards that, we can actually be able to make a difference. We know that, for example, IRV at the global level, the Gates Foundation at the global level, public education intervention have been shown to work through both the private and the public sector. And I think if we do not do that, we shall come here a couple of years down the line, because we know that right now, almost 100,000 women in Africa have cervical cancer. In the next 15 years, if we do not do anything to stop that, it is estimated that about 170,000 women will be diagnosed with cervical cancer by 2030. I'm sure we don't want to do that. I also want to point out that even as we think about availing screening service, HPV vaccination to girls, we must also continue with secondary prevention through screening for cancer, for women who have lesions that are not yet cancerous, and treating them so that we can actually be able to get rid of the pool of women who, if we do not do anything at this time, in the next few years, will die from cervical cancer.
Now it's my pleasure to introduce Diana Summers, and she is from Gavi. Gavi was already mentioned before, the Global Vaccine Alliance. So Gavi is helping countries availing the vaccine, the HPV and other vaccines, and at reduced cost. But you have to be in Gavi eligible country. And if you are doing too well, then maybe you don't meet the criteria anymore. So please, Diana, explain us a little bit the role of Gavi.
It's a great pleasure for me to be here and to talk to you about HPV vaccines and Gavi support, and also going to be talking particularly around public-private partnerships and how this has contributed to reducing the cost of the vaccine. I also wanted to just mention that Kenya was one of the first Gavi-eligible countries to apply for and get support for an HPV demonstration project, which is now in its second year. As we heard in the previous sessions, there is a lack of access, particularly to treatment, also to screening. And HPV vaccines are key to prevention. And Anne McMichael of American Cancer Society in our last session talked about this very safe and effective vaccine, which currently can reduce around 70% of cervical cancer cases, it's not the silver bullet, but it's a very important strategy in preventing cervical cancer. Currently, there are some 75 countries around the world that have introduced HPV vaccines nationwide. Unfortunately, most of those countries are higher income countries, and the low income countries, which have unfortunately the highest rates of cervical cancer burden, are not getting sufficient access to those vaccines. So it's the role of Gavi to bridge the equity divide and to help low-income countries have the same access to the same vaccines that are available in more wealthy countries. And to do that, it's really key to have a public-private partnership model. And I was going to actually give you a presentation on this, but I think that maybe the slide's not available, so I'll just walk you through it. In terms of more specifics on Gavi's programs, I'll be giving a Gavi update, which is my kind of annual update here tomorrow afternoon, so you're very welcome to join us there. So how do we reduce the price of vaccines? And as my colleague was saying, the vaccine is around $100 plus in higher income countries. And Gavi has a model whereby we mobilize resources, which provides long-term predictable funding. And secondly, we shape vaccine markets so that the vaccines are affordable and sustainable. And I'm not just talking about the period during which those countries are eligible for Gavi support, because yes, support is designed for lower income countries. The idea is that by lowering the prices, these prices will continue to be low for low-income countries for a long period afterwards. And one vaccine manufacturer made the commitment last year to have a 10-year price freeze, so that's around the $4.60 mark. One vaccine manufacturer made the commitment to freeze the price for all countries that are graduating from Gavi support who apply to Gavi for HPV vaccine support. So to do this, to shape vaccine markets, to lower the price, we aggregate demand, or otherwise called pooling demand, from over 70 Gavi-eligible countries. And to be a Gavi-eligible country, the cutoff or the threshold is the gross national income of around $1,500. Also for our vaccines, and that covers our entire portfolio of vaccines, there needs to be a 70% what is called DTP3 threshold. This is to gauge the strength of health systems to deliver the vaccines adequately. So we mobilize these resources from donors, from funders, private foundations, which finance the purchase of the large-scale demand for vaccines. And this predictable funding plus the pooling means that we create an incentive for pharmaceutical companies to provide vaccines for countries that otherwise would not be able to access it. So the prices are much lower because we're able to pool demand. And what is also interesting too is that because we pool demand for other disease burdens, it also creates an incentive for pharmaceutical companies to invest in the research and development of new vaccines, particularly suited to the disease burden of countries such as in Africa and in Asia. So now I'll just turn to my presentation, which I'm going to walk you through because we don't seem to have it. Two concepts I'd like to give you is what's an unhealthy vaccine market and what's a healthy vaccine market. So an unhealthy vaccine market is one where there's limited supply of the vaccines, the demand is unpredictable, the prices are high, as I've just expressed about HPV vaccines, and the result is that countries don't have access to these life-saving vaccines. So what is a healthy vaccine market? Well, we have sufficient supply, We have healthy competition, and that includes incentivizing manufacturers in emerging economies to produce the vaccines. And generally, those vaccines that are coming from emerging economies are already at lower prices, and also creates a healthy competition to reduce prices across all vaccine manufacturers. And the result is the right vaccines reaching communities at low and sustainable prices. So when markets work well, everyone benefits. Countries benefit from access to appropriate quality vaccines. Communities benefit from improved health. Manufacturers benefit from predictable demand from previously untapped market, because as I mentioned, it encourages them to invest in vaccines and also in product presentations which are more suitable for extreme climates and conditions. And the donors benefit from having their contributions have the greatest possible impact. They're getting more bang for their bucks. The other point I want to mention is that there are basically 3 prongs to ensuring a supply of appropriate quality vaccines. One is balancing the supply and demand, one is the cost of the vaccine, and the other is the appropriate product. Now, there is no point to reducing the cost of a vaccine to a point where a pharmaceutical company will not be able to invest in the research and the development and the production of the vaccine. So those 3 elements have to be balanced. Otherwise, you push vaccine manufacturers out of business. So we don't want to jeopardize the supply of a vaccine or innovation in the research. So it's very important to have the balance between those 3 components. That's supply and demand, the cost of the vaccine, and appropriate products. I'm just going to now switch, because I'm just conscious of time, because I think we've been through all the major concepts of shaping markets. So I'll finish off with the HPV vaccine market influence. Gavi's approved the support of HPV vaccines in 2012, and in 2013 the first applications were submitted to Gavi. Since then, with almost half of all Gavi eligible countries have applied for HPV vaccine support. And we're currently supporting some 24 demonstration projects, and there's also been supporting national introduction in Rwanda, which was a continuation of a donation program, and the planned introduction in Uganda. When you put all the numbers together, it means that by the end of this year, 1 million girls will have been vaccinated against HPV, and by 2020, over 30 million girls will be vaccinated against HPV in more than 40 countries, and the majority will be in Africa. We've also reduced the HPV vaccine price. At the lowest price back in 2013 was $13 per dose. Gavi, with the support of the HPV vaccine manufacturers, were able to reduce that price to $4.50 per dose. And then with the 2-dose regime, which was approved by WHO last year, that means a full course of HPV vaccines will cost $9. That's $9 to Gavi. Of course, for low-income countries, Gavi provides the HPV vaccines at 20 cents per dose for the poorest countries, which is a co-financing requirement designed to ensure sustainability.
Thank you so much, Diana, for running us through the Gavi work and for highlighting the fact that indeed prices have been reduced. But the other good news as well, that till last year, I think, we were recommending 3 doses of vaccine, and now there is a WHO recommendation after studies that are showing that 2 is as good as 3. So this has an enormous impact, not only on the costs, but also on feasibility. And last but not least, manufacturers have been mentioned already many times in this panel, and there are 2 pharmaceutical companies who are manufacturing the vaccine, and one of them is with us. So it's my pleasure now to invite Mr. Farooq Shahmasjiva from Merck to tell us about the role of a company, the role of a manufacturer in HPV vaccine.
Thank you so much, Marlene. It's a real pleasure to be here. I wanted to share just a couple of things with you on our topic today, and I'm really going to cover three things. Talk about cervical cancer and why it is a problem from our perspective. Secondly, highlight a few things around our commitment as it relates to cervical cancer broadly, but HPV vaccines in particular. And last but not least, I'd like to open the door a little bit on the conversation on universal health coverage and how HPV vaccines fit into that. Allow me to be a little provocative and say that I'm a bit baffled, actually, by the lack of attention in some respects to cervical cancer. We've made immense progress, I think, in some respects, a lot of which has been highlighted today. But if we just come back to some of the statistics, you know, we know that every 2 minutes a woman dies from cervical cancer in this continent. So the real question for me is that how is it that we find that acceptable as a global community and as Africans and as partners? Again, from my perspective and our perspective, it's really about there's two things that are highlighted with that kind of challenge, and one is that it starkly illustrates the impact of inequality and inequity when it comes to women's health. Number one. Primarily because it strikes, it is a disease that can be easily prevented through HPV vaccines and also through comprehensive approaches to cervical cancer prevention, treatment, and screening. And secondly, when it comes to economics, and this is something that private sector companies do know something about. Basically, the morbidity and the mortality that's caused by cervical cancer affects women in their prime and their productive years. And so in some ways your society robs itself of the opportunity of active contributors to society and to the wider aspirations that we all wish across the world, I suppose, to be richer and to allow us to do the things that we have reason to value. What is unique about cervical cancer, of course, is that it can be prevented. We have safe and proven and effective vaccines against cervical cancer. We also know that certainly from ourselves, Marlene had mentioned two companies. We're one of the two companies who has partnered with Gavi, who's one of our most important partners in bringing HPV vaccines to the developing world, and Africa in particular. We know that vaccines are one of the greatest public health stories. And from our perspective, our unique vaccines have helped prevent a number of diseases, and we're certainly committed to eradicating this disease from Africa and all over the world. Let me talk a little bit about our investments in public-private partnerships to give you a bit of an example of some of the things that we've participated in. I've mentioned Gavi. So I won't go into that in a lot of detail, but just to highlight two other ones. One was the Gardasil Access Program, and the Gardasil Access Program was fundamentally about supporting countries to gain operational experience in designing and implementing HPV vaccination programs. About 21 countries had gained experience there, and with regards to Africa, about 600,000 doses were delivered. I think a good example of a success story, Diane had highlighted this, is Rwanda, who had learned from that experience and has implemented a national program. Secondly is an initiative that a colleague from the last panel, Anne McMichael, had mentioned, which is the Pink Ribbon, Red Ribbon Alliance, where it's really, investing in showing that comprehensive cervical cancer prevention and control programs, that they work and they're possible across the continent. I've talked a little bit about global initiatives. At the country level, we've engaged quite heavily as well when it comes to a number of technical areas and supporting ministries of health when it comes to HPV vaccination programs. Everything from cold chain capacity, strengthening health systems, to wider issues around advocacy. and public policy engagement. Just on that last point, an example here in Kenya was in April during World Immunization Week, where together with a number of partners, we launched World Immunization Week. And to get together and get back to the central message on the importance of immunization as one of the most cost-effective interventions in preventing disease, morbidity, and mortality. I'm going to switch gears a little bit now and talk about universal health care. And I hope that we can have a bigger conversation about this, because as we know, the global kind of development and health agenda is moving into what's known as the Sustainable Development Goals, of which universal health care is a very important pillar. And from my perspective, the introduction of HPV vaccines creates opportunities to strengthen health systems that are really important as part of the process of ensuring universal health care, and particularly from the perspective of reaching young adolescents. That would include integrated approaches to adolescent health services, but also linking it more broadly to cancer control, as well as strengthening EPI systems, sexual and reproductive health programs, and also engaging other sectors such as education, nutrition, and so on. And I think that that is particularly important because, as many of us in the room know, we're only just starting to scratch the surface when it comes to adolescent and young people's health, and particularly when it comes to sexual and reproductive health and rights and services. And so a larger investment with HPV vaccine at its center could certainly offer an important approach to realizing the ambition of universal health care. Of course, it's without saying that in many respects it requires innovative strategies for hard-to-reach populations and hard-to-reach girls who are potentially out of the school system, as well as through universal access to comprehensive cervical cancer prevention and control programs. I just wanted to highlight one thing, and Anne had spoken about this earlier as well, and that's the perspectives of survivors. In many respects, we talk about comprehensive cervical cancer prevention and treatment and screening programs, but also there are some really tough issues that from that perspective we have to contend with. And they are issues such as stigma that a lot of women face across Africa when it comes to cervical cancer. And that is something that collectively, if we are serious about universal health care, that we also have to address. Let me finish then with just one final point. And that's that, as a community, I really feel that we are on the wave of something great in Africa. I was born on the continent. I consider it my motherland in many respects. In terms of something great in the continent, it is really imagining a world where one day no woman should die unnecessarily from cervical cancer. We have the tools. And I believe that, we must continue to build on the great momentum that we've had so far. And thinking about things, coming back to this theme of public-private partnerships, being innovative about it, what have we learned, but also how do we take that to the next level? Because the central challenge for us is, of course, the evidence that we know, but it's also the broader challenge of fundamentally not forgetting that preventing this disease is about securing the future of Africa, but it's also about giving hope for millions of African women and girls who are the future of the world.
Yes, hello. My name is Njeri Mbokwa, and I am with Basalis Life Sciences and also the National Cervical Cancer Coalition, New York chapter. And my question really is to the Merck representative and also the lady from Gavi. It is very important, yes, to have the vaccine available at a price that most governments can afford. However, I wonder, is there an additional requirement to these governments to have comprehensive screening for cervical cancer and not just use the vaccines as the only preventative measure? Having VIA and pap smears as well.
Alinda Ndenga from Jepaigo, Kenya. I'd like to understand the age limit for the vaccines. More so, the women in the reproductive age who may actually test negative during VIA, can they qualify for the vaccine?
My name's John Wambua Msau. from Machakos County. I'm the coordinator for Herbalist Society of Kenya in the Lower Eastern. Now my question is, according to the panel, or what we have heard, it is as if from day to day, there is an increase of cancer. This is indeed scary. As a person, a participant in this occasion, what do you think can be done so it is as to stop cancer? Thank you for the global concern, for the development of the vaccines. I'm a herbalist by profession. I use vegetation to treat cancerous and other complex disease conditions. Now, according to me, or my own views, there could be a serious consultations with the scientific and the traditional healers, and of course, a serious research, so that we can get cure. I use 15 weeks to treat cervical cancer. I've got medicine for hepatitis B10 and B12. This is a medicine we can develop, we can plant. But imagine, we have got a problem with biodiversity. The vegetation or the ecosystem is being, let's say, the climatical changes and also extinct of the medicinal plants which we use is at stake. Now, would like every country to have a microclimatical reverse, because maybe a lifestyle is causing infections of cancer. Therefore, we could try and look for a way to stop cancer as well as treating it. Therefore, the answer is just at our feet.
I'm from Kisumu, Tumaini la Maisha Health Services. One concern that I'm having when addressing cervical cancer, we intend to involve women much more than men. Yet we find that men are the people that are affecting women. I think we need to come up to address both male and female in fight against cervical cancer, so that at least men also should get to understand, especially in the village, whereby when you talk about cervical cancer and you want to talk about reproductive organ of a lady while men are there, that stigma is too much. And it is my call, or just to make it more, to involve men and women all together so that we can help our mothers and sisters.
Thank you very much, sir, for this very important call. And indeed, that's also WHO, and many partners are calling for the girls and the women. They will suffer from the disease, but let's not forget that it is a sexually transmitted infection, so that also men have to know what is going on, and they are part of the problem and part of the solution. So we have to work all together, and mainly in the prevention also involve men, inform them, make sure that they are in favor of their daughters and the girls being screened, and that they are in favor of vaccinated and in favor of early screening and treatment. We have 5 questions, and I'm going to start with Dr. Keegan to answer some of them.
I think the success of any adolescent program involves what you involve as services. As you do policies as countries and counties, and especially countries, when you're doing your adolescent policies, you must ensure that all services required are actually in the policy, so that when implementing the policy, you're actually having the services. If you look at our new policy which is about to come out, one of the strategies of the services that they need to be given is HPV. So that is in the programs. There was a second question about screening. If you remember when I mentioned our program, there are different areas that you do actually in a program. Our emphasis has been on there are different parts. There's a prevention part, then there's actually the screening itself. That's early detection. But all must go in concerted to get a good program working. For us, I think the prevention part needs to be strengthened. That comes to what the fellow was saying about men involvement. In prevention, it's just not HPV. It also involves the ABCs, okay? Abstaining, being faithful, condoms, male circumcision. Those are things that come in prevention of HPV. So we must know those are important things of the program.
Those are very good questions. Let me just add a little bit on what was said. Ms. Jerry Mbugwa, you asked about comprehensive screening. I think you need to expand that to include not just screening, but the entire program, from the planning stage to financing to the execution to monitoring evaluation, has to be looked at in its totality. And even at the time of public-private partnership, that interaction is at the comprehensive level. It cannot be piecemeal. It cannot be at only one point, only at screening or only at vaccination, but the entire process, including private sector driven financing as well, and looking at different economic models to support this kind of programs. The issue, Professor Mushemi, on sexual adolescent, and to tie it up with the male education, I think these are taboo issues in terms of discussion, but you will agree with me that progress has been made in discussing these issues, especially since the advent of HIV. Even putting an advert in the newspaper was a taboo, discussing condoms or sexuality. I think we need to take it progressively, that we, like a ladder, that we climb each rank one at a time. We cannot go to the 10th rank when we are still at the first rank. So I think we have made significant progress, and we need to recognize that and continue to make this progress, that we should not be discouraged. Taboos are cultural, and culture changes. So we will continue talking about it in schools, in churches, in mosques, and as we talk more about it, then the taboos fall away.
Thank you very much for the question from the lady around the comprehensive screening. I think we have to understand that, the idea of preventing and controlling cancer is pretty new territory for a lot of countries. And for this reason, Gavi has, as part of the HPV demonstration projects, encouraged countries to include a cervical cancer control and prevention plan or strategy. Gavi's support is country-led, so it's not for Gavi to make this a prescriptive demand for countries. It encourages countries to do this. So similarly with the HPV demonstration projects, it's learn by doing. So it's giving the space to countries to be able to test the delivery of the vaccines, whether it's school-based or health facility-based, and also to set up the mechanisms needed to coordinate between the different ministries, Ministry of Education, the Cancer Control Department, Ministry of Health, the expanded program of immunization team, to work together in a coordinated way, which also includes having a cervical cancer control and prevention strategy. The other question I wanted to refer to is around the age limit of the vaccine. Gavi is a funder, and also, as I mentioned earlier, it shapes the market around HPV vaccines. We're not a technical agency as such, so as part of our partnership, WHO is a very critical partner for Gavi, and we follow WHO recommendations around HPV vaccines. And the latest WHO recommendation is to vaccinate girls between the ages of 9 to 13 years of age. And perhaps, Marlene, you'd like to explain a little bit more about the technical behind that. But the idea is in order to address the public health burden and also to ensure that the HPV vaccine program is cost effective. To date, we're providing vaccines for that age group.
Thanks, Diana. Maybe Dr. Dirango, you can explain why we are choosing this young age for the vaccination.
Okay, thank you. Actually, those are very good questions. And if I may begin with the recommended age, one of the things is that the best value for vaccinating, a woman would be before she gets infected with the HPV vaccine. I mean, with the HPV, with the virus itself. Absolutely, almost all of us get infected with the virus, when we start our initial sexual debut. And many of women are able to get rid of the virus. Actually, 8 out of 10 will be able to get rid of the virus within 2 years of infection. And the small proportion in whom the virus persists are the ones who eventually become candidates for cancer. Unfortunately, one is not able to identify those in whom it will persist and in those whom it will not persist. Hence, it also means that this age group, before they actually start having sexual activity and getting exposed to the virus, is actually an opportune, the so-called, golden window for us to be able to interact and be able to provide not just the vaccine, but comprehensive adolescent, youth, reproductive, and sexual health services, that talk about many things, lifestyle change, so that behavior, so that young men or women who start smoking at this age, can we be able to tap into that opportunity so that they can actually set in place lifestyles that will be useful for them. We also know that many of the diseases that occur in adulthood later on in life, actually, the causative factors happen around the time of adolescence. HIV, we've heard about HPV and cervical cancer. So it would be wise for us to engage youth, adolescents, and engage the community. So that as you are discussing this, I want to thank Allah for pointing out male involvement. If you look at the terrain that you're working, for example, in Kenya, we have the community health strategy, whereby we are working with the community at that level, at the household and the community level. So can we be able to utilize people at that level, both men and women, young and old, so that we can be able to tackle the challenges that you are facing collectively? And I want to believe that if we do, if we actually work together, we can actually be able to make a difference. The pharmaceutical industry, of course, evidence shows that they can be given to women who are older, 26 years for one, and the other one can go up to 45 years. But really, the most beneficial age would be the girl who has not been exposed to the virus. And it is important for us to remember that the younger women is also likely to mount a better response to the vaccine than the older woman. So it is important as we are interacting to be able to see who would be the most beneficial candidate, especially given that resources are scanty. However, in environments where resources are available, there's no harm. It may protect the others against subtypes of the virus or types of the virus that they may not have been exposed to. I think, if you may allow me, is that I also want to, thank John for bringing out the fact that we need to work together. The traditional and modern practitioners of medicine, we really need to interact and see how can we be able to look at evidence, to look at science. Can we be able to study some of these compounds that we use to be able, and again, how can you use the network that a traditional practitioner uses to actually reach out to both men, women, young and old?
Just one small point to add. And since it was a little bit more directed to Merck, and that was by Jerry on comprehensive approaches, and the simple answer to that is yes, without a doubt. But what's interesting, and I think what's important, is that it comes back to this question of how one goes about sort of doing that, and innovations in public-private partnerships. There's a number of initiatives that have been going on at a global level and at a country-based level and a community level. And I think the real opportunity for us is to be thinking about what are the lessons learned, what are the new things that we can do so that we can leapfrog in ways that, that we would otherwise not be able to do. I think that's the first point that I'll say in terms of moving forward as part of a comprehensive approach to cervical cancer prevention, control, and treatment. The second point is that, and it's a bit related to the previous panel, is that we are talking about cancer. And so in many respects, it's also linking those approaches to figuring out how we can have a broader approach when it comes to cancer generally. And I think the reason also why that's important is, once again, is that there might be synergies, but also broadly speaking, if our objectives are around universal health care, that would also offer us a very important opportunity.
So I think this was really a great panel, and I was kind of intrigued by what Farouk was saying, that the global community, do we accept one woman to die every 2 minutes of cervical cancer? And the answer is definitely no, otherwise we wouldn't be here. And this is, the global community is getting more and more interacting. Also, we have Gavi, we have many more partners and stakeholders. We have the Global Fund. You all know the Global Fund, HIV, malaria, tuberculosis. But now they are also moving in, how can we expand, for example, to reproductive health? How can we also contribute to cervical cancer? Because cervical cancer in the topics of today, cervix, breast, prostate, is actually a low-hanging fruit, so to speak. We know what the etiology is. We know how we can prevent. We know how we can detect early, screen, treat before we go to cancer. And a lot more needs to be done for those patients who unfortunately still develop their cancer. So this is already more further advanced than the other topics like breast cancer, prostate cancer. So we have to move, and we are sure we can eliminate cervical cancer, at least reduce substantially. And as it was said already, no woman should die unnecessarily of preventable causes of disease. So having said that, I'm going to close this panel. I think we have the fact that this meeting takes place here is also showing that the global advocacy is increasing. And this group of First Ladies who are meeting here in Kenya now for the 9th time, so 9 years, and I had the privilege to be with them in many, many other conferences. And I've seen it growing over the years, more possibilities, more methods, more tools. So there is a call of action from Nairobi, from this conference, that is really calling for eliminating cervical cancer. That's why we are here, and I want again to thank the First Ladies, the Princess Nikki Foundation, the government of Kenya, and all of you to work with us together jointly for these goals.